So, respected chairpersons and panelists, today my topic is all NOACs are the same. It is a very important topic in the current scenario or in our day-to-day practice because there are three NOACs available in the India. One is dabigatran, second one is the apixaban, and third one is the rivaroxaban. So, if we go minutely, then we have to categorize our patient in certain subsets of the group in which we can select the best NOACs to the particular subsets of the group. So, my theme of this presentation is how to choose the correct and most efficacious and beneficial safety as well as efficacious anticoagulant to certain confusing scenario. So, I will first of all I will compare the traditional therapies like vitamin K antagonist, then NOACs with aspirin. Then we will discuss regarding the pharmacokinetics of all three NOACs, and then we will see some real world evidence data, and then we will discuss the best anticoagulants in certain groups like elderly patient and renal compromised with the high risk of bleeding and the diabetes. So, this will be the outflow. So, if you talk about the stroke, we all know that the main risk of the atrial fibrillation is that incidence of the stroke is very high in the AF patient. So, our goal is to how best we can prevent the stroke with the drugs. So, it was started with the aspirin, and it was seen that there is 22% relative risk reduction if we compare with the placebo. Then things moved forward, and then we see the vitamin K antagonist like warfarin or acetrom, and it was shown that there is 38% relative risk reduction as compared with the aspirin. Then we move forward, and then we discuss the NOACs, the role of NOACs in the prevention of the stroke in the AF, and again it is additional 19% relative risk reduction if we compare with the vitamin K antagonist. So, antiplatelet monotherapy is not recommended right now for the stroke prevention in AF patient regardless the stroke risk according to ESC guidelines. So, I will put some data here. Asian patient were the 4 times risk of the intracranial hemorrhage. Warfarin is the effective treatment for managing the stroke risk in the AF patient, but the role is limited by because of its narrow therapeutic window. Patient time to the therapeutic range should be kept as high as possible and closely monitored. If a patient on TTR can't be sustained above 70%, switching to NOAC should be considered. So, this is the limitation of the warfarin. As for that AF registry, AF patient receiving vitamin K antagonist in the Asia spend majority of time outside the therapeutic range. So, if we go by the closely monitor patient, the most of the patient you will find in your day-to-day practice that the INR is labile due to the certain reasons, or most of the time it is not in the therapeutic range. Warfarin has a long half-life and show slow onset and the offset of the action, and there are issues in the perioperative anticoagulation or bridging. So, there are the interaction with the drug and the diet as well. Warfarin administration require frequent coagulation monitoring and frequent dose adjustment. These are all the basically real-time challenges if we put our patient into the warfarin or traditional anticoagulation. So, the NOACs came into the picture, and it started from the 2009 that introduces the dabigatran into the picture with the RELY trial, and it compares dabigatran versus warfarin. It was found useful in terms of the efficacy, in terms of the safety features. Then again the things moved forward, and in 2010 came with the ROCKET AF trial. It compares the rivaroxaban versus warfarin, and then again in the 2011 we came with the Averroes trial, and that it compared with the apixaban versus aspirin. So, then again the things moved forward. In 2011 the Aristotle trial came. It was a landmark trial with 18,000 patients, and it compared apixaban versus warfarin, and the results was in the favor of the apixaban in terms of the safety and in terms of the bleeding profile as well. So, if we conclude this in the short, The NOACs, the advantage over the warfarin that it is having rapid onset of the action. There is no significant food interaction, so low potential for the drug and drug interaction, no requirement for the close coagulation monitoring, established criteria for the dose adjustment in the elderly patient and in the case of the renal impairment. So these all are the potential advances of the NOACs if we compare it with the warfarin. If you go by the mechanism of action, you will see that the warfarin, it inhibits the all coagulation cascade right from the upper to the lower ladder. If you talk about the rivaroxaban, apixaban and endoxaban, it decreases or inhibit the factor 10A, while dabigatran inhibit the thrombin. So if we compare the pharmacokinetical profile of the warfarin versus other NOACs, like mechanism of action, we all know that the warfarin is the inhibitor of the K-dependent factors. Dabigatran is the direct thrombin inhibitor, while rivaroxaban and apixaban are the direct factor 10A inhibitors. If we talk about the oral bioavailability, there is more than 90% oral bioavailability of the warfarin, while dabigatran 6.5, rivaroxaban up to 100%, and apixaban is up to 50%. If we talk about the prodrug, dabigatran is the only prodrug, rest of these are the no prodrug activity. If we talk about the food effects, definitely we all know that the vitamin warfarin has a great interaction with the food. Again, with the rivaroxaban it is yes, and 20 milligram and 15 milligram dose need to be taken with the food, while dabigatran, apixaban, there is no food interaction. Similarly, the renal clearance is a little bit low in the warfarin, and again with the dabigatran it is 85%, then rivaroxaban it is 33%, and apixaban is around 27%. So these are the overall pharmacokinetic comparisons of these NOACs and the warfarin. Now I will come to the data that favors the validates the role of the apixaban, and it was taken from the Aristotle trial. It was a big trial comprising of 18,000 patients, and the dose was selected is the 5 milligram BID. There is 2.5 milligram BID was again a dose which was selected by the criteria that is known as the ABC criteria. A is more than 80, and again body weight is less than 60, and serum creatinine is more than 1.5, then you can choose the 2.5 milligram BD. So it was compared with the warfarin, and the patient was randomized with the CHATS-VAX score more than 1, and then if we see the primary efficacy endpoint in terms of the stroke, then we see that the apixaban is more beneficial as compared with the warfarin. If you talk about the safety features like major bleeding, again apixaban is more beneficial as compared with the warfarin. So key secondary outcomes like all-cause mortality, intracranial hemorrhage, GI bleeding, and ischemic stroke risk, again the data favors the apixaban as compared with the warfarin. So with this thing you came to know that the NOACs is a very beneficial in terms of the managing stroke risk to the AF patient. So if you talk compare with the NOACs minutely with the certain doses with the dabigatran, rivaroxaban and apixaban. I will not discuss endoxaban here because it is not marketed in the India. So there is two recommended doses of the dabigatran. One is 110 milligram BID and then again 150 milligram BID. Rivaroxaban 20 and 15 milligram single dose, apixaban 5 and 2.5 milligram. That compare the safety data, and you can appreciate that if you give your patient to the 110 milligram of the dabigatran, you will have some safety features. But if you give the 150 milligram of the dabigatran, there is again the chances of bleeding is high. Similarly, rivaroxaban, but if the apixaban, either of those, either 5 or 2.5 milligram, it is more beneficial as compared with the warfarin. Similarly, if you see the intracranial hemorrhage, 150 milligram BID dose of the dabigatran, if you choose into your patient, the chances of bleeding is high as compared with the 110. Rivaroxaban again with the 20 and 15 milligram of the single dose is again better than warfarin, but the chances of bleeding is still high because curve is approaching towards the right. Apixaban either 5 and 2.5 milligram dose. In the both dose, the intracranial hemorrhage chances is little bit less as compared with the rivaroxaban and the dabigatran. So my point is to choose, if you choose dabigatran, then if you choose 110 milligram, it is less efficacious, and again the chances of you can get the benefit of the less chances of bleeding. If you choose the 150 milligram of the dabigatran, again the chances of bleeding risk is high. But if you choose the apixaban, either dose 2.5, I think my time is miscalculable. So if you compare this, the major safety outcome regarding the stroke, ICH, death and major bleed, apixaban is clear-cut benefited in all that safety and the efficacy data as well. So in short, I will compare the elderly patient, renal compromised patient, high risk of bleeding, and the diabetes patient, because these all are the subcategories in which you have to wisely choose the NOAC and you have to give best NOACs to your patient regarding in terms of the safety as well as bleeding. So with the benefit of the apixaban versus warfarin, it is consistent that in the AF regarding of the age, owing to the higher risk at the older age, apixaban is the much better molecule as compared with the dabigatran and the rivaroxaban. Similarly, in the renal patient, we all know that the renal patient are the different subset that differently behave in terms of the thrombosis, in terms of the hemorrhage, and it's a double-edged sword. We take care of the creatinine clearance level in each follow-up of your patient. If you talk about the relative comparison of all that NOACs, we find that the apixaban is the more beneficial in the renal failure, and it should be the better choice among all dabigatran, rivaroxaban, and the other molecule as well. So apixaban is the better safety as well as efficacy profile in the kidney patients. Even that there are some recent studies in which there was found that apixaban is beneficial even in the hemodialysis patient or end-stage renal disease patient. So in the CKD patient, apixaban is much more better and beneficial molecule as compared with the other NOACs. If you talk about the high risk of the GI bleeding, then again apixaban is the more beneficial.
Just come to the takeaway message.
I'm just concluding it. So in summary, if we see that the apixaban 5 mg BID shows superior efficacy and safety at the same dose with the dabigatran 150 mg BID. In the elderly population, apixaban is a favorable safety profile. In the renal failure, the first choice will be the apixaban 5 mg BD or even 2.5 mg BD. Even in the GI bleeding, apixaban has shown numerically lower GI bleeding effect as compared to warfarin, and in 2017 expert consensus apixaban will be the first choice of the drug for elderly and in the patient with the high risk of the GI bleed. So this is all my talk. Thank you.
Yeah. Thank you, Dr. Gautam, for choosing the best NOAC is $1 million question, and Dr. Gautam has tried his best. So the answer will not come from efficacy studies because there are no head-to-head studies for efficacy. All the trials, all the NOACs have been compared with VK with at least non-inferiority design or at best a superiority design. But if you look at the safety, as Dr. Gautam has shown, there are multiple high-risk groups where bleeding is a challenge, like elderly, like diabetic, like renal failure. Probably in that scenario, as the data by Dr. Gautam shows, that apixaban probably fares better, and with the latest addition which showed that even in ESRD patients on dialysis. So if you are looking at safety, I think all the drugs are there. If you are looking at efficacy, bleeding, safety, bleeding, then probably apixaban scores. Other efficacy, all the drugs are same. There are no head-to-head trials to prove that one NOAC is superior to that. Okay. But propensity match scores have shown that if you look at bleeding, probably apixaban scores, because again there are no head-to-head trials. Yeah, so you have taken up registry data where the physician is free to choose his drug, but you know that all those studies are prone to bad bias. But still, I think Dr. Gautam has done a good job and trying to show us that when bleeding is a concern, probably apixaban scores. With efficacy, I think all the three drugs are probably equal as per the randomized data.
Yeah, thank you,
Comment
Mr.
from
Chairman.
my panelists?
We have just exhausted.
I definitely agree with you. Of course, we don't have a comparative data regarding each NOAC, but in select population like renally compromised elderly, perhaps apixaban would be a better choice.
Okay, Mr. Chairman, we'll have to move on to the next presentation as we have exhausted the total time for Dr. Swaroop. Thank you, Dr. Swaroop.